Not sure, okay. Yeah, cool.
We'll just use that one.
Oops, to move that one off.
Yeah, there's a clicker as well.
Okay,
thank you.
There we go. Is that showing okay on there?
Okay, thank you. Good afternoon. My name is Vikram. I do the reproductive medicine unit clinic related to hemoglobinopathies at UCLH. Thank you, Bernadette, for including the topic that often gets left behind. We've had some cutting edge science from Ben and lots to learn. My topic is going to be a bit boring, so I hope you don't go to sleep. So, background. Why am I talking about this today? Because it's a little less talked about subject when it comes to reproductive medicine and the effect of various treatments for hemoglobinopathies or hemoglobinopathies themselves when it comes to fertility or hormone health. So we know there have been lots of advances in transfusion medicine, there are ion chelation therapies, and things have become better with time. And so we're good at managing in terms of chelation, in terms of ion toxicity, and that's led to many improvements in terms of hormone health, fertility options available. But that needs to continue. There are still lots of areas where we don't do as well as we could do, and that's what we're going to look at. And of course, as women are living longer with these conditions, we are thinking of their long-term health, what is the impact in their 40s, 50s, 60s, and beyond. And so menopause comes into picture. A lot of them may have early menopause or medically induced menopause because of the interventions. How do we suppress menopausal symptoms? How do we improve their quality of life and look after their health post-menopause? So iron loading, as we know, and probably know much better than me, is that it can lead to multiple organ damage or complications that includes endocrine organ dysfunction and subfertility. And there are many comorbidities, whether it's diabetes, effect on heart, effect on kidneys. All these need to be factored in when discussing options for managing menopausal transition. Again, this is a slide which probably is usually used when I do, say, talks for GPs or primary care physicians, but it's mainly we're looking at women with beta thalassaemia major. That's been the biggest cohort of women I will see in the clinic at UCLH, but I'm going to also talk a little bit about sickle cell at the end. But there's lots to cover. I will try to fit that in 35, 40 minutes. Effect of iron overload on reproductive health. And Pippa is going to go after me, so I'm not going to talk about men. I'm only going to talk about women here. And so we're looking at, right from beginning, it's delayed puberty or delayed onset of secondary sexual development, then going on if the cycles are happening naturally, natural menstruation, oligomenorrhea or amenorrhea, and of course, oligo or anovulation, where women go into hypogonadotropic hypogonadism, especially in thalassemia major, and that would mean there is secondary ovarian insufficiency. Those are just mentioning what can be the effects of iron overload right from puberty until the reproductive age. And why does that happen? And we know that it's the HPO axis disruption, the hypothalamus, the pituitary, and the ovary. There is a problem in the talk between the pituitary to the ovary that causes disruption. There's impaired FSH and LH secretion. FSH, LH are very low or absent, and therefore there'll be reduced pituitary sensitivity to GnRH as well, which means that there will be hypogonadotrophic hypogonadism. The ovaries won't be doing egg activity, they won't be producing a lot of estrogen. But also there is the iron-free radical reactive oxygen species damage that's directly damaging hypothalamus pituitary, the central part of the axis. Is it damaging the ovary? That's where the controversy lies. So we certainly know the iron is causing pituitary problems, hypothalamic signaling to pituitary doesn't happen. Traditionally, we've thought that the ovary may escape this. The iron toxicity may not be much, but that's changing a little bit with time. So the question is ovary actually spared from iron toxicity? Because initially, over the last 20, 30 years, studies suggested that intrinsic ovarian function, especially in women, say, aged below 35, is spared, it's not affected. And so you would expect them to have same number of eggs, same ovarian activity, if you could replace the FSH, LH again. Few recent studies around 5 or 10 years in the last decade or so have suggested that actually that may not be true. And if you look at the marker of fertility or ovarian reserve, AMH level, it tends to be lower than age-matched control women. So there is some detrimental effect of the disease, of the iron overload potentially on the follicle pool or the store of eggs. And most studies indicate that AMH levels are inversely correlated to ferritin. So higher the ferritin, higher the marker of iron overload, you do find that AMH levels are lower than you would expect for the age or the clinical situation. And if you go by assuming that this is true and future observational data actually suggests that this is technically an effect, then what could be leading to this? It's the reactive oxygen species potentially, the high iron concentration. There have been laboratory-based studies which show that the high iron does cause damage to cell function, protein synthesis, damage to DNA, and these are studies which were done on oocytes. Again, impaired folliculogenesis in ovary, impaired luteolysis or implantation embryogenesis at the time of fertility treatment. These are all thought to be the mechanisms why you may find that the iron or the oxidative stress may be causing ovarian reserve to be lower in these women. We did our own study to know what was our cohort of patients like. We tried to do a 10-year longitudinal study. Took a bit of time for us to pull the data, but this was basically part retrospective and part prospective study at UCLH, and we looked at the markers of ovarian reserve, the ones which are commonly done to assess fertility in transfusion-dependent beta thalassaemia major women, and we tried to compare the results to healthy women who did not have BTM. We had about 52 control women and 17 women with the transfusion-dependent thalassemia, and I won't go into too many details, but what we tried to do was get the background information, look at their age, BMI, the background medical history, what their periods were like, and then we compared markers. For example, we compared FSH, estrogen levels, TSH, anti-Mullerian hormone, which is the main fertility marker, and a scan antral follicle count. So antral follicle is basically the small follicles you see in the ovary at any given point in time, and we tend to do it in the early part of the menstrual cycle to assess somebody's ovarian reserve or egg store. So we looked at the main markers of fertility for these two groups of patients. Then we tried to correlate that looking at their ferritin levels, looking at their cardiac T2, liver iron, thyroid function. Many of these are much beyond my expertise, so I had to rely on my hematology colleagues to interpret these. So what did we find? We found that serum AMH level, estradiol levels, and antral follicle count were significantly lower in women with thalassemia as compared to the controls. The low AMH levels were noted in both groups of women, those who had the hypog, which means they had no pituitary signaling, but also those with retained menstrual function. And then, of course, serum AMH levels correlated with AFC. So not just one marker was down, the follicle count also was lower, keeping in with the low AMH levels. And these are actually the tables which will show you the values of it, the AMH and the AFC statistically significant and correlating with the iron. So what we concluded from the paper was the AMH and the AFC were lower, and this could suggest a direct impact of either the background pathology or the toxicity, the iron overload. Although we do very well with chelation, there is still some background iron which may be causing damage. It could be the result of treatments that some of these women go through. They may be having an impact on the ovarian folliculogenesis, but there's certainly evidence of low ovarian reserve there. So clinically, what does that lead us to? Is that the long-held belief that the gonad may be spared may not be true in all women. And so the two most important discriminatory markers of low ovarian reserve are certainly low in terms of women with BTM. The significance of that being, I still see in my clinics women being referred when they're getting close to the age of 40, who probably think that their fertility may be preserved, and that's because of the traditional thinking is that if their ovaries may be spared from the effect of iron. So the message there for anybody who works with women with thalassemia or other hemoglobinopathies as we see ahead is to try and have the fertility discussion way earlier. Try and get them to see either a fertility or a hormone specialist much earlier, even a decade earlier. Because if they have left it late and they are close to 37, 38, 40, and then thinking of starting a family, not only the age is going to decline their ovarian reserve, but you've got the added bit of their hemoglobinopathy, which actually will decline it further. So rather than leaving the discussion at 35 or 40, it may be worth setting that scene maybe when they're getting to their late 20s or early 30s to say, have you thought about this? Because there can be some impact of the background condition on your ovarian reserve. So of course, fertility treatments is not the topic today because I can talk the whole hour about fertility side of things, but just to mention that ovulation induction or pulsatile GnRH or IVF, these are the backbone of fertility treatment if someone can't conceive naturally. And of course, in males, I'm going to leave that there. So again, I won't repeat the chelation. The role of chelation, chelation is very important. From an early age, you do find that women who are well chelated will do better in terms of sometimes maintaining their menstrual cycles, needing less help with fertility later, or of course during pregnancy. And therefore, this is something the hematologist help us all the time with. And genetic counseling should never be forgotten. Whenever a woman with hemoglobinopathy will want to start a family, you have to know the partner status, and they may need genetic counseling for as some of the conditions may be eligible for PGD, pre-implantation genetic diagnosis. I'm going to skip the pregnancy bit. So key messages in terms of ovarian reserve, in terms of fertility side of things, is that early discussion of fertility issues, chelation therapy from early age, critical, essential, and of course liaison with hematologists, obstetricians when it comes to pregnancy care. But what about hormones now? So we've looked at the impact on ovarian reserve. Hormones, of course, are affected in most women with significant hemoglobinopathy. And there are three situations here. One is secondary hypogonadism. So when the pituitary is affected because of iron overload, they will not be producing FSH-LH, so ovaries will be quiet. That's a state of hypoestrogenemia. They will not be producing a lot of estrogen and will need hormone replacement until the age of 50. Second, many women will have premature ovarian insufficiency, whether it's because of underlying condition or their genetic predisposition, or because of treatments such as the cutting-edge treatments we just heard about. They can have premature menopause, and the last is natural menopause. Many of our patients are doing so well, they're now getting into their 50s and 60s, and they're going through the menopausal transition, noticing some of the symptoms. They go online, they Google the symptoms and find, oh, I'm into menopause. Why did nobody talk about this with me? So of course, we have to be prepared for that. Now, this is a general list of things we often look at when we are managing symptoms during menopause. And again, it's a multifactorial, a sort of a holistic approach when we come to menopause and managing symptom. It's lifestyle modification to try and minimize symptom, changes at workplace, making the woman better equipped at workplace to handle symptoms. Nutritional interventions can help, such as phytoestrogens. There are alternative therapies that would include homeopathy or acupuncture, CBT, and a few others. And then you've got non-HRT medications. These include things like SSRIs, gabapentin, and then finally HRT, hormone replacement therapy. And all of these will be aimed in menopause at one, improving quality of life, making sure the troublesome symptoms are off. Second, some of them will have added advantage like HRT, which will preserve bone health, is beneficial for heart health in the long term, and we're going to try and balance those benefits against potential risks. A word about hormone replacement therapy, and this is in news all the time for good reasons and bad reasons. It's probably one of the most controversial medications ever in the history of medicine, according to me. So the type of HRT dose, route of administration varies. So what is HRT? First of all, it's replacing estrogen, replacing progesterone, and for some women, in fact, replacing testosterone, depending on indication. And the kind of HRT we use, the dose, the route, there's a layer of complexity in women with thalassemia. So it's much more simpler in healthy women with no background issues, where there have been lots and lots of studies about benefits and risk. If you look at the cohort of patients with thalassemia or sickle cell, very little is known about what HRT does what, benefits or risk in this specific group of women. So we extrapolate. We think that what holds true for women without medical issue does hold true for women with thalassemia or sickle cell. And we use similar regimes, but we have to correct for the background comorbidities. So the specific data are missing. So let's say if you have a woman who has had premature menopause or early menopause, so premature is below 40, early menopause is 41 to 45. So anybody below 45 having menopause, one would always recommend hormone replacement to the age of 50. That's age of natural menopause for majority of women. That's to protect the bones, protect the heart, and hopefully improve some of the symptoms due to lack of estrogen. Then for women above 50, so this is average age of menopause for majority of individuals. Above 50, we say this is natural menopause. This is not early or premature. So you've had your lifetime of estrogen, either naturally or with HRT. If the symptoms persist now or new symptoms appear with natural menopause beyond 50, then the discussion has to be benefits versus risks of HRT. Because as we saw, there are many non-hormonal approaches to managing symptoms. And for some women, that's first line, that suits them well. For others, HRT will be life transforming. So if you give estrogen, progesterone, and then balance that out against any side effects, you'll find that they do much better. It's very individual. We tend to avoid traditional synthetic hormones, which used to be used 20 years ago. So we have natural estrogen now, natural progesterone, which is called body identical, and we tend to favor that because that's got least risk of problems such as thrombosis or increasing risk of breast cancer. That's very different from the traditional HRT when we were taught 10, 20 years ago that would have a significant risk of thrombosis or breast cancer. Again, we try to go for transdermal routes. So the big transformation in HRT in the last 10 years is use of patches or gels. We don't have to swallow tablets of hormones because when you swallow estrogen, it goes through the liver, increases clotting factors and thrombosis risk. If you take estrogen transdermally through the skin, it does not do that in healthy women. And we are seeing the similar effect in women with thalassemia or hemoglobinopathy. But caution there is we don't have very big specific data. So we always look at benefits versus risk. A lot of women see us annually, and we go through benefits versus risk and decide whether to continue long term. These are the guidelines which were published this year. I think it was Perla who introduced me to the group. And these are really clinical care standards which we published for women with thalassemia. And we've kind of specified there, when do we suspect menopause? Which symptoms do you attribute to menopause? Because there are so many symptoms which sort of cross over, like hot flushes, or night sweats, or joint pains, or headaches. These are very common symptoms which you can confuse between hemoglobinopathies and the menopause. So how do we try and monitor them? When do we think it's worth giving HRT? Which women should be eligible? We've kind of summarized this in the clinical care standards, which is available. A quick word about sickle cell and ovarian reserve. You see a similar trend, and we know that sickle cell disease, because of its problems with vessel occlusion, infarction, can have impact on the ovary. Very little data, again, very, very small observational studies, not much known about the long-term ovarian reserve in women. This was the latest one from PLOS ONE, and it did show that women with sickle cell disease have lower ovarian reserve, have lower levels of AMH as compared to controls who are healthy. You can see the difference in the mean AMH being 13 and 7, and I'll talk a little bit more about it in the questions. This was a qualitative study looking at interviewing women and then doing focus groups. Again, a small study with limited number of participants looking at sickle cell disease and menopause. And if you read there, almost all participants felt that they had no discussion about menopause as they went through their life. They found that the pain crisis, hot flushes improved from perimenopause to menopause, but actually the genitourinary symptoms persisted. So dryness of vagina, bladder symptoms because of lack of estrogen were the main problems in the menopause group, and often not talked about. The participants were frustrated because nobody addressed menopause-related symptoms. And of course, they mentioned that providers were dismissive of their symptoms. This can happen because we often think that the symptoms may be related to background medical issue, and menopause often doesn't come into mind unless you start thinking about it. And so continuing that theme, there's paucity of literature about menopause and sickle cell, small studies of women, as I said, which does show that they have low ovarian reserve, and it's overlapping symptoms that are easy to miss, but no studies specifically look at HRT in this group. So again, we extrapolate data and say that transdermal may be better because we want to keep the risk of blood clotting low. So transdermal patches, gels, sprays are still the first line for sickle cell and menopause. So that's it. That's a quick summary about what we see, what we think has been changing about the effect of iron on the ovary. And of course, HRT now will be more and more used in this population. So as we use it over the next 5 or 10 years, I think we'll have much better data specific to women with hemoglobinopathy. And hopefully I will report that in 5 or 10 years. Fingers crossed. Thank you. Thank you for listening.
Thank you very much. Any questions online so far? Not yet. Any questions in the room? Bernadette?
Anyone else?
No.
Hello. Thank you. I've massively neglected our participants in this, so I'd be interested to talk more about that with you. But so we do an annual review set of blood on all of our thalassaemia and our sickle patients. We include hormone profiles. I kind of request them and look and see if they're in normal ranges, but that's when I pass it on to one of the doctors. Can't hear the microphone. Can you hear me? Yeah, that's better. So we don't record an AMH in our patients, but you're saying at the beginning that's one of the really important markers. Is it something that we should monitor over a period of time as an assessment tool so you can see what's happening every year or every 2 years or something, or do they wait till they come to you to do it?
So I'd probably take the second approach, and that's because not everyone will want to know about fertility. So one of the things you come across is some women or individuals may say, I'm not wanting to know more. AMH is a very tricky hormone to interpret, and so they may not want to have that extra information, and they find it difficult to make decisions. They may be pushed into having interventions they don't want. What is important is to bring up the discussion and see whether they would like to have it. And so certainly that's something at some point in the follow-up when you see them annually would be worth having, and saying that there is some indication that there is a background effect of your condition. If you would like to have further tests, then refer to the fertility. They can have one-off AMH to know where they are, and a few other tests, the hormones in the scan. That would give an idea about what the future looks like. And they'll have some counseling about not delaying things too much beyond 35. As long as they are then happy to follow up at some point 2 years or 5 years down into the clinic again, we tend to say you don't need to have annual AMH. When situation changes or if there's any other medical update, that's when we'll do it again. Doing it every annually or yearly basis or frequently may be good for research, and that's something we could look at is following trends of this hormone in this specific cohort of women. That would be a very nice project to do, but we'll have to do a sort of ethics in a study for that.
So one of the ways getting access to that resulting epoch and seeking out,
Yes.
provide them with information. I think you might
Yeah.
what you
So I know wasn't really part of your presentation, but you touched upon it on one of your slides about hydroxycarbamide. And we work in paediatrics, and we speak to a lot of parents, and a lot of the reasons they don't want to start their children on hydroxycarbamide is because they're worried about fertility, especially giving it pre-puberty. And I just wondered if there was any update on that data, because I know when I have spoken to people, they've said, oh, there's not much that we know at the moment.
So it does still look like that. So it looks like there is minimal impact. Having said that, there are a couple of small observational studies which suggested that if you look at the long-term ovarian reserve of these individuals, if you study long-term trends, there could be some minimal impact. So for example, their reserve will be lower than what you would have expected had they not had hydroxycarbamide. So it's not that you cannot use it, or one has to be worried about using it, because the medical benefits will still outweigh that small impact on ovarian reserve, but there is a minimal impact. And to kind of put that in perspective, we're seeing the same, say, with women who have SLE or rheumatoid arthritis. A lot of women get given methotrexate or other potent drugs, and traditionally we've thought that doesn't have much effect on the ovarian reserve, so it's offered without any discussion per se. But you see a similar effect, is that those women, when they come to their late 30s, may not have the same chance of having a family. They might have to start earlier, in their early 30s, unlike other women who can maybe leave it until late 30s, early 40s. So there may be a slight impact there in reducing your store, and maybe an early menopause. We need much better data. No one has done that work. I need funding, if there are any funders listening.
Sorry, you mentioned in one of the slides about nutritional support. Did you? Did I make that up?
Yeah.
Can you talk a little bit more about that?
So some women don't like to use hormones. So it's a little bit different if you're giving hormones for hypogonadotrophic hypogonadism. They take HRT when they are young. They will continue cyclical HRT or combined HRT until 50, then gradually come off. But for menopause per se, if it's early menopause or natural menopause after 50, some women don't want to use HRT. Certainly they have strong views because of traditional myths about strong risk of breast cancer or blood clotting or stroke. Then you try to go all the non-hormonal way. Some women will choose that. So you can improve your diet, first of all, for your general health, the same tips as normally you would give. Phytoestrogens help a subset of women because they are very weak estrogens in the diet: soya, tofu, lentils, pulses, legumes. They're about 1,000th of an estrogen effect, but if you eat sufficient, not loads, I guess you can't eat too much, but if you eat on a daily basis sufficient amount, a lot of women find the menopause symptoms improve. So that's the natural way of going about if you want to concentrate on diet. And of course, the supplements like over-the-counter supplements, Menopase and others have probably no impact. So don't waste money there.
You said to carry on, so for our ladies, HRT potentially to the age of 50. Because I've had quite a lot of my ladies, particularly my transfusion-dependent thalassaemia patients, probably very keen to carry on with HRT, particularly in my patients who are late 50s to 60s who were profoundly hypogonadal for until their sort of mid-25, 30s. So I just wondered, is it like lifetime estrogen exposure, or is it, is it...
So it's individualized.
Yeah.
There's no one answer for everyone. So if, let's say, we look at just women going through natural menopause, no hemoglobinopathy, there's no upper limit to stopping HRT. You can continue into your 60s, 70s till end of life. Most women will take it between 50 to 65, gradually lower the dose, come off. Some will continue in their 70s, 80s and longer. We don't have good data even for those women after 70 because there haven't been really good studies for this population. So we'll know from now on in future how they do. For women with hemoglobinopathies, hypox, certainly till 50, there are only benefits for bone, for heart, for symptom. There are no risks. When the transition happens beyond 50, the discussion we need to have is now you're going to potentially have added risk, which is a small increased risk of breast cancer. Every 5 years that you continue taking the combined HRT, that risk will be tiny, maybe 5 in 1,000, but it will go up. And at that point, many women will say, no, I don't. I'll come off the hormones, that's fine. If you carry on, because you still feel better on it, and you carry on for another 5 years and have another discussion. So it slightly will depend on what the symptoms are when you come off, what your bones are like. If you're osteopenic, it's still worth continuing another 5 years. So overall picture decides how long you go on. Very individualized.
Thank you.
Thank you.
Brilliant. Thank you very much for that. Brilliant. And continuing with our our theme, though this time from the
boys' side.
The boys' side, as it were, is Miss Sangster.
This is for the clicker. If you don't want the clicker, you
Yeah, I can use it there. Shall we just do that?
Who's one of our consultant urologists with a specialist interest in andrology based at UCH.
Thanks, Emma. We'll just load up the disc.
Yeah.